Hello, and welcome to part 2 of the interview I got to do with Bree, the acute care NP. Doesn't that rhyme so nicely? I was like, oh man, your name was like made for social media. But this is part 2 of the interview. If you have not seen part 1, make sure to go back and check that out. It just ended up being really long, so we chopped it into 2. So here we are. Basically, if you're watching this for the first time and you haven't caught part 1, we're just looking into the life of an acute care nurse practitioner that works in the intensive care unit. I don't know. I was going to say ICU and then it came out weird. What her day looks like, advice she has for people who are aspiring to get into that, and all sorts of good stuff. So let's roll right into that. It is. Yeah. Is there anything that you like can't do in your role in terms of like that a physician would have to do that you can't do?
Yes. And that's going to vary from APP to APP. I mean, I do like to say I love to be autonomous and I love working with the group I work with, but I do also I am not a physician. I was not trained as a physician.
For sure.
There's so much more that they know that I will never know. So we do always work in collaboration like that. If I'm making a plan, I'm going to present it and they're going to yay or nay it. We're going to do it together.
Yeah.
To me, that's a beautiful model. So there are a lot of things that they can recognize and treat that I don't. There are some procedures they can do that I cannot do. I do not do tracheostomies. I am learning to do bronchoscopies, but I have not gotten enough yet to be independent on that. But yeah, that's a whole nother thing. But some APPs are competent to do chest tubes, some are not. It just depends on your experience, how many you've done, how many people have proctored you. But in my hospital, we're able to do a whole lot. Other places I've been, I can't intubate. I can't put in chest tubes. It's sort of culture driven by the hospital that you work in.
Yeah. And so when you learn those, is that kind of like you said, you get like proctored with it, like they kind of watch you you learn a bunch and then they watch you a certain amount of times and then they're like, okay, like.
You have to get credentialed through the verifying bodies at the hospital, and it's different for every procedure. I want to say for bronchoscopies and chest tubes, it's 10. Intubations maybe about the same. So you really need direct supervision for that many. Which in COVID, I've gotten a lot of them. Before that, I didn't do a lot of chest tubes. With COVID, I'm like, chest tube here, chest tube there. All right, I'm good. It's been a good opportunity.
Yeah. And I kind of like that they give you sort of a framework for it, because primary care is like the Wild West. They're like, I mean, I'm sure technically, but you can do it. So go do it. And you're like, I would just really love there to be like, something where I get a check mark or something.
Yes. Someone actually watch me do this and make sure that I'm doing this the right way.
Yeah. Like I would prefer to just not watch a YouTube video and then like march in and be like, all right, toenails off, let's go.
Yeah.
You can just
and
watch me and tell me this is fine.
I will tell you, outpatient procedures are way more intimidating than inpatient. Way more intimidating. I did a whole rotation through Winship at Emory, and I'd had to do bone marrow biopsies on people, and these people are awake. When somebody is awake, it is a much more intimidating process.
You have to like small talk with them.
Yeah.
The whole time.
Yeah. Like, or like, when the drill falls off the hip, you're like, oh, what part of the body did I just hit there? Like, you tell your face.
Everything's fine. Can you still wiggle your toes? Okay, perfect.
Yeah, I mean, there's a lot. Yeah, no, I'm fine. My intubated people and knowing the procedures I got to do, I'm good. They're intimidating procedures at first, but nah.
See, and then they just sound so fancy. I'm like, that sounds so hardcore. Like, look at that go. Is it a pretty procedure heavy thing, or does that? I mean, it could be job dependent, I'm sure, but like, if you like procedures, this would be good.
Yeah, ICU in general is very procedure heavy, particularly as APPs, because most places are pretty consistent in this, and that is that the APP generally is the one doing a lot of the less risky procedures, I guess. So lines, art lines, central lines, fast caths, your APPs are almost always going to be the ones putting those in. Some places, the physicians still do them. The place where I work, they still do them. But a lot of it is going to fall on you. Paracentesis, thoracentesis, bronchs, intubations, chest tubes. That's the gist of the procedures. The LPs, oh my gosh, LPs are the worst. But
yeah,
we get to do a lot.
That's my nightmare, but I'm so happy for you. Like people would come into my office and like with anything, they're like, "Can you do this?" I'm like, "I don't want to." Like, please don't make me slice anything ever. And they're like, "Oh no, I trust you." I'm like, "You shouldn't." Like, please go to urgent care, please. But so I'm just very impressed by people who can go in and be like, "Oh yeah, let's just, we're going to put a tube there." Like, that's wow.
Well, it wasn't to start with. The first couple times you do anything, you're like, oh my God.
Yeah. And did your school prepare you a lot for that, or was a lot of that on the job type of?
Yeah. So this is very interesting. So I went to Emory, and Emory, does a great job with clinical placements. But the downside to that is that typically you're fighting residents for procedures. So as an NP student, I did not do a ton of procedures. I think I did 2 central lines, maybe. I did not intubate. I think I did 2 lines, and that was all I did as a student.
So, and it's a hard sell for a patient to be like,
yes.
I even have that thing outpatient where you're like, I need them to do a PAP. And you're like, they are a student. And you're like,
yeah.
Yeah. Like, oh, can I have them do that? So I totally get that. So it's mostly work based then with like, hey,
it was totally on the job. And I have a lot of students I precept, they come through, and I know they all want to do procedures. Everybody wants to do procedures when you're a student. I get it. But the thing about it is, NB students are going to go, even within the acute care role, are going to go in so many different directions that it's really, I think, better to focus once you get on the job and you can be trained by a physician who's doing that all the time. These are risky things we're doing to people. These are not IVs. This is not a blood draw. These are risky procedures. Yeah. So I do have students do some things. It depends on the skill level of the student, the complexity of the case. A lot of different factors go into weighing whether or not we're going to do this or not, but it's a big deal. So I didn't get a ton, but you'll get it when you get your job. As you get your job, trust me.
Yeah. And that's almost better because then you're doing it in the institution you're going to be working at. You'll know the exact charting system, how they like you to do it. Like it's almost probably better. Because I could imagine them coming in, how people say like, oh, you have bad habits, coming in from other places. And they're like, oh, I don't like how you do that. And you're like, oh, well, it's good. I don't have any skills. I'm just a blank slate. Like, let's go.
True.
What is there anything that you've kind of learned being on this end that now you look back at your past nursing self and you go, oh, like, I'm so sorry. Like learning things on this where you're like I remember always like making fun of them for I'm like, it's just Tylenol. Like, come on. And then like being on the end where you're like, okay, like, I think you can take Tylenol. Like, I think it's going to be fine. Like,
actually, it's so funny you said that because my first order that I ever put in was for Tylenol, and it took me like 7 minutes. I was like, okay, up to date, Tylenol. What are the side effects of Tylenol? Like, I already know these things.
You look up your liver labs. Like, okay, I think this is going to be
so overwhelming. You take on so much more liability. You really underestimate that when you're a nurse. You're going to have to transition to that as an NP, but you have no idea how much it weighs on you. And so the same thing with like palliative care. Like in ICU, we do a lot of things to the human body long after the human body should be gone. We can keep it alive. And it is hard for nurses at the bedside to watch that. It's hard. I get it. I felt the same way. So bedside nurses tend to do a lot of pushing, like, what are we doing? What are we doing? What are we doing? Can we stop? Can we stop? We're torturing this person. Well, and I remember thinking the same thing. Like, can you talk to this family, please? Or I'd talk to the family. And I clearly, looking back, took some way beyond liberties than I should have in speaking with these families about why I thought they should stop, because I felt strongly about it. And then when you go through school and you learn about prognostication and you learn about outcomes and looking at the numbers and who actually does improve, maybe I should have been saying half that stuff. And I certainly now, when the nurses call me, like if I've already talked to the family once and we've said, okay, things are not looking so good, what do you want? And they want to do everything. Well, that's their decision. It doesn't help them for us to keep hammering them over and over. But I think at the bedside, you don't see that whole picture because you're not involved in all the discussions. You don't necessarily see the long game. You only see the short game. So there's a lot of things I did not recognize when I worked at the bedside. A lot of things I thought I knew. I thought I knew a lot about vent management.
Oh yeah.
Keep an SiO2. That's how you raise your oxygen level. That's what you do.
Oh yeah.
Oh my God.
Yeah.
Yeah. So many things.
Yeah, I always say that I was a way more confident nurse practitioner before I became one, because when I was a nurse, I was like, oh my gosh, like just do this. And I'm like, oh, I don't want
that
let
is
me
such a good
agonize over this
description.
for a moment. Like, and I just had no idea about like, yeah, how much, like you said, like how much it weighs on you and how many patients you have and how much that's all going in your brain. And so I feel like the way I looked at residents and then I was like, oh my gosh, you have how many patients? Like, vomit. Like,
I know.
but I think that's a nice thing to like realize in retrospect. And then you're like, oh, I wish I could, I might do things differently, but
yeah.
And I wish everyone could just like shadow. I wish residents could shadow. You know, I think so much of that would be helped with like if residents could just shadow a nurse for like a day and we could shadow them when we're nurses, like it would just, I was such more of an understanding nurse when I was in NP school because I was like, okay. Like,
you walk a mile in someone else's shoes. It changes your perspective on what they're facing that day, for sure.
I'm like, this is interesting. I got it now. How long did it take you to feel comfortable?
It probably took me a year to feel comfortable. It took me 6 months to not be white knuckling the steering wheel driving in. And then it took about a year I felt pretty comfortable. And at about 2 years, I felt really confident. At this point, I feel like I can handle pretty much anything that comes my way. I mean, there's plenty that comes in this.
That's awesome.
You're like, what is that? Let me just go figure that out. But it's rare. Most things I feel very, very confident in taking care of. But yeah, a year.
That's awesome. And I feel like, I wonder if that almost lines up with most jobs. Cause I said the same way. I was like, for the first 6 months, I was known to cry on my way to work, like out of terror. And then like from 6 months to a year, I kind of was like, okay, I could imagine a world where I can do this. And then at 2 years, you were like, anything can walk in the door. And like my anxiety level going in was just not there. I was like, it's going to be fine. Yeah. We're all going to be fine. Like, which is such a nice point to hit. It just takes a minute.
Yeah, it is. And then you start thinking, maybe I should change jobs.
Exactly. You're like, oh,
maybe you don't if you're not a job hopper like myself, but
oh, I am very much a job hopper. I'm like, well, time to learn a new thing. Let's go. What did your orientation look like?
So, okay, any of my coworkers who are watching this, I love you dearly. You know I do. This was a problem for me. So the issue is I was hired at a time when they were short-staffed and there was no structured onboarding at that time. I had also never done any clinicals with them. So I got 6 weeks, which they felt like was enough because the person before me had 2 weeks. She had 2 weeks because she had been a student with them for like 6 months. So when you're a student, you already know all you know the system, you know the consults, you know who you need to call, when you need to, where you can admit someone to, some of the bureaucratic stuff, and you learn their ways of doing things. I didn't have any of that. So I came in new to them, and 6 weeks was not enough time for me, particularly we were in a phase where our census was high. So I think they kept saying, well, it's okay because once you get off orientation, you're never going to be alone. You're with a doctor the whole time. Well, that's fine. Except that when I got off orientation, like day one, they gave me 8 patients and we were slammed. And I admitted my 9th at 7:00 at night. And then they killed me for making a mistake that I made, which I still didn't say. I'm like, oh, but I'm like, you know what? I was literally just treading water, people. So it was not the best for me. But what I've found now that I've been doing this for a while and I've onboarded people even beyond me, everybody needs something a little different. And I think it's just good to establish before you go into a new group, what is my onboarding going to look like? How will I get feedback and who's going to give it to me? And identify those things before you even start so that you know halfway through that time frame, you're going to go to this person. You're going to say, how am I doing? Where am I at? This is what I need still, so that you're constantly discussing what is needed so you can develop that person in that skill set more.
Absolutely.
So when they are off, they can. And that's kind of how we do things now. But it's not that way at a lot of places, particularly if you're going to work in like a critical access hospital, a rural area where you may be the only NP there. I mean, you're going to encounter a lot of different scenarios. So that was my experience. I would have liked a lot more.
Yeah, I know. I completely understand that. That was mine. I like walked in. She's like, all right, we're going to look at the computer for 4 hours and then your first patient's at 3. And I was like, great.
What do I say?
yeah, this is okay. Here we go. But oh my gosh, I totally,
Yeah.
and I love that you said the thing about like setting up the expectation of when you will meet beforehand, because it's so much less awkward. I didn't do that. And then you were kind of like having to ask, but then you felt like you were in trouble, but you're not. And then, or if they came to you, then you were like, oh, I'm in trouble, versus like, it's very normal. Like, of course you're going to meet like all the time. Like you should, to be like, hey, this is where I see you're doing great. Like, this is where we can work on this. Like, this is normal. And even going out, like you should have a 6-month review and a 1-year review, like, because it's awkward in the middle of it. Be like, can you evaluate me? Like, please, what is, I don't know. I did not do that. And it was a mess.
Yeah. Hindsight.
Yeah. Charting. What is charting? How much of your day is spent charting?
An astronomical amount. And this is really like a big pet peeve for me. I'm really glad you bring it up, because this is something that, I don't know about your schooling, but for me, I mean, I knew it would always be a challenge. I knew it would be a challenge, but I had no idea the extent of a challenge it would be. No. And I knew when I was in school that it was not normal that it would take me 6 hours at home to write a note on a pretend patient. Like, that's not normal. How am I going to see people out there? You know, and I just underestimate. And then, you get out there and you got 8 patients. You don't have time to do 6-hour notes. So, and here's why I think it matters, and maybe they taught us in school and I just didn't pick up on it. But to me, note writing is where you learn. It's where you process what's wrong with your patient. It's where you compile the pertinents that help you make a diagnosis properly, and where you make your plan. It all happens in the note. I mean, you could be thinking, as you become more advanced, you'll be thinking through these things as you're looking at someone. But particularly when you're new, note writing is where it's at. So when I started, I knew it was important. I knew it mattered, because that's how I think through things. But it would take me forever, because I would have to spend time reviewing the literature. Like, I'd start writing a note, and I think, oh my gosh, what is that an acronym for renal failure, and when do I do dialysis? And you'd have to stop and go back to the literature and pull it in. So it would take forever. And it was just like, and then you get it figured out, and then you come back the next day and it's the same thing. It's reinventing the wheel. So unless you have a very good memory, or you can recall all of that evidence-based stuff they taught you in school, you're going to have to be doing repeated efforts at the same thing over and over again. And so I did this for like 4 straight months. I was there until 11 o'clock every single night, because I could not finish my notes, and I wanted them to be good notes, because that's how you care for your patient. And it wasn't until I don't know why, it just occurred to me that we have these EMRs that have dot phrases in them. If you don't know what that is, this is they call them smart phrases or dot phrases. Everybody has them. I've used Cerner. I've used Epic. They're all in there. It's AI within the system that allows you to create like a bank of text, and you can have it say whatever you want it to say. And then you can, when you're writing something, you just type in dot whatever, and it pulls over that body of text. And these are like pages or notes or books. I think about them like books, and you can spend time curating a huge library of these books, these phrases for you to use. And so as I started doing that, I'd type out, well, these are the things I need to do if the patient's in renal failure. These are the steps I need to take to determine whether or not dialysis needs to be done right away. And so the next time I encountered AKI, I just typed .AKI, and it would pull over that information. Or I'd have like a template that had everything written out, patient admitted with this creatinine, and here's what it currently is. Here's the isonos. I need to do this. I need to do this renal ultrasound and the plan. And so then all I had to do was edit it specifically for that patient. And it was like notes were just like this after that. I mean, it was literally like a light bulb went off. I went from hugely ineffective and staying late every day to suddenly, slowly, after developing those, being able to be better at my job and able to go home on time. And it was just like, I can't even tell you how powerful that moment was for me. So I am a huge fan of the stop phrases. And every student I have through is like, what are those? And I'm like, how do you not?
How do you not know? Yeah.
So I had a student last year that said, well, can you make me a copy of this? I was like, it's huge. There's tons of them. I mean, which ones do you want? So what I ended up doing was writing a book. I ended up putting it all into a book. And then I was like, well, I'll just, give the book out to my students. And then as my social media platform kind of took off, I was like, well, maybe I should just sell this book. And that's kind of how I segued into like a book on note writing. But it's
Oh, that's awesome.
Yeah, it is night and day as far as transitioning as a new NP. And even as a student, like, it helps you to, write things out. I remember the first note I wrote as a student, I had like 3 problems. And my preceptor was like, this is an ICU, so you should have about 13.
We have more than 3 problems.
We have a lot of problems, Brianna. Literally. I was like, so I don't know. I highly advise you, if you're new or you're a novice, look into your dot phrases. It will change your life, people.
Oh yeah. And is your book available? Like, I can link it down below.
Yeah.
Perfect. We'll do that. Is it more acute care? Perfect. Yeah. I have all of that's her website. We'll put it up again. And all of her information will be linked down below. Is it more geared towards acute care, or is it kind of like everyone can benefit from it?
Yeah, it is. It's I don't see how this would be applicable in the outpatient arena. It's really designed
it would be hard.
Who are, hospitalists and ICU providers. That's really what it's designed for. The problems in there,
an amazing resource.
Yeah, I think
love
so.
that.
It's been very popular. A lot of people have purchased it. So I think there's definite need for it out there. It's the book that I would have wanted.
Oh my gosh. Exactly. And like, even like you said, like, it gives you something too for the days when your brain's not quite with you as much, and you bring it in, you're like, oh my gosh, like, I need to do, like, I would do that all the time. I'm like, oh, like, I need to also order this, like, duh, like,
yeah.
But my brain was like over there. And I was like, thank goodness my past self, like,
I know. Oh yeah, still to this day, I'll pull it up. I'm like, oh, did I write that? That's right. I am supposed to do
wow, look at me.
Oh yeah, I forgot about doing that and that and that.
Exactly. I'm like, oh no, good job, past self. I appreciate you. Well, that's awesome. Yeah. I'll definitely link that down below and give that out to all sorts of people, because that's an invaluable resource. I left all of mine on my computer, and I could just like bash my head into a wall. When I left my job, I was like, oh my gosh, I didn't download them.
You got to start all over again.
But at least I know how to now. Now it'll be less looking things
that's true.
As I go. It'll just be like, okay, let me just type the dumb thing out and put it in here. Okay, so charting heavy. Yes. I feel like that kind of comes with the.
I think that's in any role. I mean, I don't know many NP, except maybe if you're doing a procedure, or like IR NPs. I don't think they do a lot of notes. They just do a lot of procedures.
And IR, so far I've talked to an IRNP and palliative care, and they said they were much more like, palliative care was like more just like like a social note. Yeah. And then IR, she's like, I mean, it's templates because it's a procedure. Yeah. So you just like do the same thing. You bring in your template, and then you're like, well, let me insert your name, and done.
Yeah. They spend their day going from patient to patient. It's not in the note writing. That's true. But there's not a lot of roles like that.
No, there really aren't. And oh my gosh, primary care is like all new. I'm assuming, like, I feel like in the IC, like in the hospital, and then primary care are your ones where you're like, let me write you this novel that no one will ever want to read.
Right.
What do you feel like now is the stressfulness of the job? And one being like, you are rocking babies in the nursery, and 10 being like, you are the only nurse for 10 toddlers.
Well, I think this could also vary based on your environment. If you're that critical access and you're the only one, it's probably a 10.
Oh my gosh. Yeah.
Our sister hospital, we used to have to float to our sister hospital, and it's smaller. And I have been in situations there where there's no physician. It's me and the ER doc. And it definitely raises your butt puckering level quite a lot. When things hit the fan, you're like, okay, it is occurring to me, I'm going to have to intubate this patient, and there's no doctor here to help me. So here's my plan A, B, C. Interestingly, it makes you kind of a better provider, because you've got to think through all the possible scenarios that could happen, because you don't have a backup. So there is that. Now, at my position, I mostly work on days, and there are a lot of resources around me. Is it a stressful job? Yes, but I knew that going into it. That's kind of what critical care and ER work is. It's the people who are drawn to that are people who like that kind of thing.
Yeah, and they're dying. Energy. Like,
we like the buzz. We like just a little bit of a hit of a buzz every now and then. So that's you gotta like that.
Not rocking babies. It's the people who were like in the code. Like, I was the one who was like, I'll man the floor. Like, you do you. And then like, you're probably like, I'm there. Like, take me to them.
Yeah.
was like, I'll just watch everything. It's fine. I'll answer call lights. It's all good.
Somebody's got to do it.
I know. Whenever I was precepting, people were like, aren't we going to go? I'm like, no, we don't. No. Unless it's our patient, we don't really do that. It's fine. Oh my goodness. Is there anything else? Oh, what type of, in terms of education, is there anything that you would tell people to like look for in NP school or avoid? Because I feel like, like you said, it varies so greatly.
Yes, it does. And we are in the era of the diploma mills, and this is a soapbox that I will try and stay off of. But I feel very strongly that until our regulating bodies change the requirements for school, it is incumbent upon us as the people attending these schools to be responsible for choosing wisely. And the way I think about it is, you are going to school to be a provider, to think like a physician and act like a physician without the benefit of medical school or residency. So it warrants rigor. It should be hard. It should be hard. It's supposed to be hard for a reason. So these schools who are making it easier and easier and easier for you to get into, most of them are now waiving the GRE and GMAT requirement. Most of them are waiving the requirement to even work as an RN. I think this is a terrible idea. It makes me very, very sad for our profession. We have many people who are kind of flooding the market with little to no experience and demanding full practice authority without the competence to do so. And they're making mistakes and they're making everybody else look bad. Not only, I mean, these are human lives. These are human beings. This is not just an end goal for you. So I think that people should look for, it doesn't necessarily have to be brick and mortar. People always say, oh, go to brick and mortar. It doesn't have to be brick and mortar. It just needs to be a reputable institution, somewhere that I would always ask, who's teaching your classes? Are there any guest lecturers? If it's just one professor online, it's all module driven, you're not going to learn anything. You want to be learning from the person who's boots on the ground working in that environment. So the more guest lecturers you have, actually, the better it is.
Oh, that's interesting. Yeah, that's a good perspective. Almost like medical school. Yes. Kind of how they just bring in all their adjuncts in for.
Exactly. Yeah. And I trained at Emory, where we were associated with the School of Medicine. So we often had a physician across the street coming over to talk to us about hepatology. You know, how else do you want to learn about the liver? Do you want to learn about it from somebody who's working in hepatology, or do you want to work, you know? So I always look at who the teachers are, who's teaching your classes, and whether or not they help you with clinicals, because I think it's actually almost worse for you guys than it is for us. But if you can't, you know, trying to find those difficult rotations in OB, peds, where nobody wants to take students, it's going to be very challenging for you. So, and there's not a lot of schools that will help you with clinicals. Someone will say they will, but always just call the students. I mean, just remember, they're a business. These schools are a business. They're looking to get your dollars. So they're interviewing you, but you need to be interviewing them even more.
For sure.
Urgently than they are.
Yeah. Oh man, I feel like we could both jump on a soapbox on this. I'm just like, this is a disaster. Yeah. It
is. It makes me sad.
Yeah. And like you said, I think we shouldn't look at this school lets like anybody in. I'm like, that's terrifying. Like what? Yeah. And I don't want you to be advertising it online. I get advertisements all the time. It's like, become an acute care nurse practitioner in like 18 months. I'm like, the time, the time is not that's not, like maybe that's not what we should be focusing on. But oh my gosh. So you have to find your own clinical placements too? I always assumed that they would help you, like get them for you.
No, I went to Emory, so I did not. They offered options to me, but most of the students that I have that come through from all the schools around us, they have to find their own. The good thing with acute care is that most of these people are working in a hospital, so they have a lot of contacts with people. So it typically is not quite as hard for inpatient, because you've got a lot of different options. You know, it may not be exactly in the role that you want to work in, but you can probably find someone to do clinicals for you. So I feel like it's a little bit easier for us than it is for you. I hear nightmare stories about people trying to find OB rotations. I think, I can't help you there. I don't know many OBs. I mean,
No. I'm really lucky that I went to a school that they found them for us.
Did it for you?
And they really did. Yeah. And that was like why I went there, because I was like, I don't know any. I worked inpatient. I was like, they're like, use your network. I was like, of inpatient pediatric cardiologists? Like, That's not very helpful.
Yeah. That was a big part of why I chose the school I went to as well. Big part of it.
Yeah. I'm like, this is not gonna, what is that actually gonna help me with? Oh my gosh. No. I know I always ask, but I feel like I know your answer. How long do you think, is there a time limit or a comfortable level where you think it would be generally a decent idea if people want to go back that they should work first? Like, you need to be able to walk into the craziest of situations and feel fine, or like, because I find sometimes it's even just like not necessarily how many years, it's just like how,
what the experience
competent
is.
Exactly. What has filled those years. Is there a time that you generally tell people of like, hey, you need to get at least this much?
I mean, I think 2 years is probably the minimum I would recommend. Because I feel like that covers everybody. Now, you are going to have your outliers. You're going to have people who work in level 1s who are taking care of the sickest of the sick every day, and they're very comfortable at a year. But then you're going to have the outliers who are working at, community hospitals that maybe the ICU is not really that sick, or they are always getting the easy patients. So it's very hard to blanket the statement because it's dependent upon the person. I think that's why the schools struggle with it so much too. But I think at least 2 years, at least 2 years. I mean,
that's where I'm with. I'm like, I couldn't even like lift my nursing head above water for like a year or a year and a half. I'm like, how are you thinking of grad school? Like, I was just like still crying on my way to work, trying to figure out my life.
I mean, to me, I couldn't even think about doing it at 2 years for me and knowing the kind of person I am. No way, 5 years. But I know a lot of people want to just get in and get out. So I would say 2.
Yeah. I think I have a lot more fear than a lot more people. I'm like,
well, me too.
And then once I graduated, I was like, are you sure? Are you sure that I can just go out and do that? I'm like that.
Well, and because you care about your patients, you care about your outcomes and how your people are treated, and you got to learn it the right way because these are human beings.
And I think the gravity of it, like, you don't really realize, or at least I didn't in NP school. I was like, oh, I'm just going to become a nurse practitioner. And then when I got into that role, I was like, I am the last stop.
Yes.
Like, if I do not catch it, it might not get caught, and that could end poorly. Like, and it's just,
totally
I wish
burden.
we talked. I wish they talked about that more in school to kind of be like, hey, as a preface. But like you said, it's a business. And so I have tons of people coming to me all the time and they're like, oh, well, my school said I should just like roll right into it. I'm like, they're like, because if you're in the education mode, you should just go for it. I'm like, don't you understand that that's because you are worth tens of thousands of dollars to them? Like,
right. And they don't realize that.
Yeah. I'm like, this has nothing to do with education. It has everything to do with, you are a huge price tag and they already have you. And they're going to grant you admission and you're just going to roll right through.
I know.
Deep breaths. Deep breaths. It's going to be fine.
It's all fine.
Can you tell you've struck a nerve?
No problem. I'm right there with you. We are on the same little soapboxes. You and I stand together.
I'm glad. I feel, every time I talk about that, it's always a fun hot fucking topic. Sometimes I do it though, just to annoy the people. Anything that you wish you would like other people to know about acute care things, and then we can you can tell us all about like you and all of that you do and all of that good stuff.
I feel like this is sort of a recurrent theme. Maybe we've talked about it already, but I guess it's on my mind because I've had a couple consultations lately where people are like, I don't know what to go back to school for. I encounter a lot of NPs who work in the hospital who are like, well, I'm going to be an FNP. I'm like, okay, well, what do you want to do with that? You're going into primary care. Do you realize what that means? And then a lot of people go back for their postmasters, which is fine. You can always do that. But this is a question I get asked over and over and over again is, well, I feel like I'm more marketable as an FNP, that maybe that's what I should do. And so I'm always looking for ways to, try and help people make sense of what they should do next. And I think it's in part because I struggled so much with paralysis by analysis when I went back to school too. And my friend actually sent me this Instagram reel the other day, and it really struck a nerve with me. And it was a podcast interview. I don't even know who the interviewer was, but he was interviewing a firefighter. And he said, what is your advice to overthinkers? And he referred to a book he had read called, I had to write it down, The Horse, the Boy, the Fox, and the Mole. Have you heard about this book?
No.
Okay,
I'm going to write it down so I can link it down below.
I haven't either, but I downloaded it and because I'm a big Audible person. I've listened to it 3 times. It is
Oh my
so
gosh.
good.
Yeah.
So good. It is very different. You can listen to it in an hour. It's actually probably better to read because it's an illustrated book. It is a guy who wrote this illustrated fable. It's kind of like Winnie the Pooh type of Poohisms, so it's a lot of metaphors about hard things in life. But it's the story of this little boy, and he goes on this journey with a horse, a fox, and a mole. And one of the journeys they go on, they're in the woods, and the boy says to the horse, I can't see a way through. And the horse says, well, can you see the next step? Then take that one. And it just for some reason that just gave me chills. It just resonates so much with me because that's where it's at, right? When you're in this paralysis by analysis and you just can't make a decision, well, not making a decision is a decision. So either stay or take a step forward, even if it's not where you think you need to be in the end. I really thought I want to do the FNP things. I thought, well, I'm getting older. I'm not sure I want to work in a hospital. Maybe I like the stability of being in clinic, but what do I like right now? And I just start with what you like right now.
Yeah.
What do you like right now? What is the next step for you? And so I just love that story. And I really love that book. Now it's become part of my library.
Yeah. I love
that. Don't get too much in your head,
And it makes it so much more tangible. Yeah. And you can change your mind. Like if it then decides in 5 years,
that's right.
You're like, hey, I kind of want to go this way. Like go that way.
Yep.
Like we talked about in the beginning, like you're only going to learn from it. It's not ever like you've wasted all of this time. Like you're just going to be a way more well-rounded human, which is amazing.
Yeah. Yeah. But I find that's something that everybody struggles with. So you're not alone in that.
Oh yeah. No. And neither are you. It's a whole mess. Any resources, if people think they want to go into acute care, that you think would be helpful for them to look at, since shadowing is so hard?
It is hard. So the Society for Critical Care Medicine is our big or medical organization. This is the scientific body where all the physicians gather. This is where all the research is driven. There's a lot. If you go to their website, sccm.com, there are a lot of resources there. There are programs you can buy. They have a conference every year. This is where a lot of our guidelines stem from. So within the world of critical care medicine, this is our guideline body. AACN, American Association? Yeah, I think it's American Association for Critical Care Nurses.
Colleges of Nurses or something.
Yeah, something. It's something critical care nurses. I don't know. All these acronyms, but they are a great resource for nurses and NPs. CCRN certification through them, and they have a lot of guidelines. The consensus model, where what we talked about earlier about role delineation and where you can and can't work, comes from there too. So I think that's a good resource for folks.
Oh yeah, for sure. And that'll probably break it down so you can see the different almost jobs and responsibilities. Sometimes I tell people to work it backwards like that. Like what do you want to be doing? And then you might need to work backwards into an NP certification. I was like, because it's not clear cut. It's not, you're going to have to reverse engineer it and figure it out that way. Is there only one certification exam for adult Gero? Acute?
Yeah, that I know of. There are some subspecialties. I know palliative care NPs have a certification they can add on to in addition. I think possibly with some of the other specialties there might be. With critical care, there's not. You are AGACNP, that is your certification. I don't even know of any subspecialties within that, like neurocritical care might have something. I know they have a big society that guides them to, and I can't think of the name of it. A lot of it is just once you get into your profession, you start learning what your resources are and going to them there. And, most inpatient jobs, and I think outpatient as well, offer CME. So constantly, continuing your education through conferences is really, really good way to do things too.
Yeah. And then kind of even tailored to what your population is and everything like that. It's kind of nice you only have one exam. We have the option of 2, which is stupid because there's no difference between them. Yeah, you can take it through AANP or ANCC.
Oh, yes. No, we do have that as well too. I guess that I did miss that point. Yes. You can certify through either the AACN or the AANP. I always say AACN because I don't know anybody who does AANP.
Yeah. I mean, it seems weird the AANP would even do inpatient. So that's good to know. Okay. So pick the first one.
Yeah.
Perfect. I'm like, why do we make this so complicated? Like,
I don't know.
Nursing?
And they're like, well, which one do I need to take? I don't know.
I'm like, I don't know. Like, whatever one. Yeah. And then they change all the time. And I'm like, flip a coin. It's going to be fine. Was there a like resource you love for boards?
I used Barkley. I loved Barkley.
Okay.
I could hear him in my sleep.
Yeah.
His voice, you're like, oh my gosh, will haunt me forever. But I listened to his audio. I bought it before I started school, and I started listening to it in the car because I was driving to Emory 5 days a week. And it's good that I did it that way. But yeah, I used Barkley a lot. And I used Test Bank. There were a couple different companies I used that just had, because just doing questions over and over and over again. He had some, SCCM had some. I used a company called Mometrics. They had a couple books that I bought. Yeah, that's how I
hodgepodge. Yeah, that's I'm like that's when I was like, I'm gonna dip my toes everywhere. It's gonna be fine.
Whatever can help me. Please and thank you.
Exactly. I will take anything. Okay, so what I want you to have, like, tell everybody a little bit about you and like where you are on social media. You obviously have your book, which is very exciting, that we'll link down there. Like what you do, anything you want to talk about in terms of that.
Yeah. So I kind of, when COVID hit, I made a couple of Facebook videos where I was ranting about the fact that the parking lots were empty because, in fact, we were not allowing visitors in the hospital. And they went viral. I made a couple of them. And at that time, I kind of decided that I liked having a voice and having that platform in which to share my opinions. So I sort of segued it a little bit and started getting into NP topics. So I started a YouTube channel. I do a lot of videos mentoring NPs about going into the profession, what specialty to pick. I talk about that a lot. I talk a lot about interviewing, some educational stuff, particularly ICU. That's the world I know. So I do a lot of talks about like ventilators and bedside management. And I do like the meat and potatoes teaching on YouTube, and I do tidbits on TikTok. And when that kind of took off, and after I wrote that book, what happened was that I needed a platform in which to sell the book. And then I also needed a way in which to kind of filter down the DMs that I got, because I constantly get a stream of questions from people on DMs, which I'm more than happy to answer. But I found that it was sort of like taking over my life. It was definitely affecting my life. So I started doing one-on-one consultations on my website, where I mentor people throughout their career, whether it's, people who are trying to decide what to do, what specialty to choose. I do some contract negotiation, helping people negotiate their contracts. And I do mock interviews for people because in this job, we interview a ton of people, a lot of physicians actually, because we just have grown so much. So I've seen people interview very well, and I've seen people interview very poorly. So I do a lot of mock interviews for both jobs and college entrance. I have a college entrance one later on today. And then I sell that book. So I'm doing a little bit of everything, just trying to.
That's awesome, though.
Yeah. I mean, clearly it's not making me, I'm not going to get rich off of this. That's not my intention. I just wanted to kind of designate my time when I spend my time in helping others.
Yeah.
The guidance that I kind of wanted when I was looking at going back to school. That's sort of
what
I'm
awesome.
Yeah.
I'm trying to bring up. Oh, good. I did it. Here's her page. You can all go subscribe here. I was like, I wanted to show you because you have like a ton of really awesome videos.
Thank you.
Tons of different, like, super helpful playlists. I'm like looking through it. I'm like, oh my gosh, this is like perfect. It's kind of like it's like the acute care version of what I'm trying to do.
Yes. That's sort of what I'm feeling for. You're my mentor.
Oh my gosh. Oh, good luck.
Because the social media thing is a whole different ball of wax than getting into practice.
It very much is. It very much is. And a lot of the time I'm like, what is happening? What is going on? Yeah. It very much is. Well, thank you. So anything else you want to plug, say?
That people can follow me there. TikTok, I've got a huge following on TikTok with shorter information focused on both professional and educational content. I'd love for you to go check it out.
For sure. And I'll link all of those down below, and I'll put a little TikTok-y thing up here that's the very fancy word for it. That'll have your handle on it.
It's official.
I love that. Well, thank you so much for coming on and sharing all of your knowledge, because this is such a popular thing, and I don't know anything about it. So I very much appreciate you.
Well, I so appreciate
I think it's
you
going to
having
help
me.
a ton of people.
Very full
Yeah.
circle moment
Awesome.
for me to be on your show. So thank you so much for having me.
I love it. Thank you so much. All right. Everybody else, if you want to see more videos like this going over all of the different careers in healthcare, if you would like to share your career on healthcare, it doesn't have to be an MP or even a nurse. Let me know. Just email me. I'll put my email here and we can chat, and then make sure to go check out all of Bree's stuff. It sounds like the world of resources, which is awesome. So have a lovely day. I hope you have a good few days off.
Yeah, thank you.
Next time.
Thank
Bye.
you so much. Bye.